Yeah, we are live. Shianshi, we can start.
So, greetings and a warm welcome to all the dignitaries present here. I'm Srishi from Planet, serving as the allocated session assistant to ensure a seamless experience.
Yeah, we are live.
Planet
Shianshi, we can
stands
start.
as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, Gujarat. And the focus of today's session is Focus Series 29, ET tip and central line tip localization. So let's begin today's session, for which I would like to invite Dr. Kunal sir to take over. Over to you, sir.
Yeah, thank you so much, Shiashi. So today we are continuing with our POCUS series. So today we are continuing with our POCUS series, series 29 we have reached. And today we are going to talk about the ET tip and central line tip localization. And for that we have none other than Dr. Mohit Sani sir, who has helped us and taught us so many things throughout the year. Sir is, all of us know him, but just to complete the formality, sir is the director of NF Eco Academy Surat, India. Sir is a neonatologist at Surat Kids Hospital. Sir was editor-in-chief for Journal of Neonatology India between 17 to 22 and President Gujarat State NNF between 20 to 21. And sir has published various books. Thank you so much, Mohit sir, for joining with us. And it is a very interesting topic, as we all sometimes are confused what the tip, where the tip is, and we tend to do an X-ray, but better would be an ultrasound, so it can be a live procedure, and while doing the procedure also we can adjust the tip position. So it is a very important topic which we are going to cover today. So I'm very eager to hear from you, sir. And over to you, sir. Thank you so much.
Thank you very much. Thank you. And last time I was really sorry that there was an emergency and I couldn't do it. So today we will start with the ET tip localization and the central line. Are you able to see my slides?
Yes, sir. Just make it full screen, sir.
So basically, it is a part of the POCUS, and we have already discussed functional echo, head ultrasound, lung ultrasounds in detail. So today we will be talking about the central line tip localization and the ET tip localization with the central line vascular access. So if we talk about a case scenario, there's a 19 days old born to 20. This is basically we have covered. So this is yes. So this is a 19 days old male born at 29 weeks of gestation with 1 kg, around 1 kg weight with large HSPDA 3.2 millimeters. So baby was referred for surgical ligation as the baby failed 2 courses of the medical closure of the PDA. So there was E. coli sepsis, bilateral IVH, lung disease is significant with the high frequency oscillator ventilation with MAP of 9 and FiO to 40%. The procedure went uneventful for around 52 minutes. And in this, you can see that when the baby had that PDA ligation procedure, the blood pressures fell down. In between went up, but then this is mean blood pressures, systolic and diastolic and mean. So there is as you can see from this chart also, from 0 hours post ligation till 26 hours, FID requirement has gone up. The pH has become acidotic. The lactates, they have increased. So there is something which is hampering the tissue perfusion. And this is the echo in parasternal long axis view, parasternal short axis view, apical four chamber view. In all, you can see there is a pericardial or pleural effusion. You can judge. There are ways of differentiating it, but there was a pleural effusion post-operatively, which was hampering the cardiac contractility and the cardiac outputs. So when the chest drain was inserted, 40 ml of straw-colored fluid was being extracted, and hence the baby became better. So that means it is not only when we do an echo that we only have to concentrate on the just on the heart. you have to look around the heart also. As you can see, these are the four chamber views. There are four chamber views, and then this is LALV, RARV, and just around this, you can see there is a black color. This is a collection. So that is what that is what is important. So now this was just to show you that when we do an echo, we just don't concentrate on chambers of the heart or only the heart. We have to look around the heart. So ET tip positioning. So ET tip positioning, as we have already discussed a view that is a what we call as the arch view. So the arch view is a part of high parasternal views, and that we do from the high parasternal views in the upper one third of the sternum. As you can see, where I am keeping this probe, I am keeping the probe in the upper one third of the sternum on the right side of the sternum. That is the right subclavicular area. Pointer is pointing at 12 to 1 o'clock position. And this is the arch view. Ascending aorta, arch and descending aorta. And these are the 1, 2, and 3 branches. So this is where we look for the ET. In arch view, in between second and third branch, can you see this hyperechic shadow here? It has also been seen here like this. So this hyperechic shadow is the ET tip. So how to calculate the distance? We will talk about that. So this is the view we use. So I'm using the sectoral probe and aortic arch view to localize the tip of the ET. So ET tip, as you can see in this diagram or figure here, this is your ET tip here. This is your outer boundary of aorta. So the distance between the ET tip and the outer boundary of aorta here, this one, this should be 0.8 to 1 centimeters, 8 to 10 millimeters. So if this ET tip is less than 0.8, it means it is low. It is more in, we have to pull it out. And if it is more than 1 centimeter or 10 millimeters above here, so it means it is high. We have to push in. This is how we calculate the distance of the ET from the ET from the aorta and whether the ET tip is in the right position or the not. This is how we do that. This is the video. Okay, so this is the ET tip here, and this is the outer wall of the aorta. So here you can see this is the ET tip. So what we will do is we will look for the ET tip here. This is the ET tip. This is the outer wall of aorta. So this distance we will measure. It should be around 1 centimeters, 0.8 to 1 centimeters. So then that means the ET tip is in the correct position. This is your outer branch of aorta from ET tip to outer branch. Here you can see it is around 0.6. So it is bit low, but nearer to point. So if I need to withdraw also, we need to withdraw it by 0.2 centimeters, which is very less. So you have to stabilize the ET because sometimes with the neck position and with the movement, the ET moves in and out. So that has to be stabilized before we measure the tip of the ET. So this abdominal ultrasound neck ascites, we will not discuss in this. We will do it in the other session afterwards. So here we will directly go to the this all these things neck and everything we will discuss in our next session. So here we will directly go to the UVC, UAC visualization and the center line insertions. So this section we will do in the next Pathshala class. Okay. So first we'll talk about the UVC. So when we talk about the UVC tip, you have to follow the route of the UVC. So generally what happens when we talk about the tip and localization of the tip of the UVC, we tend to see it in the IVC, but actually the UVC is not passing through the IVC. Okay, so the UVC, this is the normal anatomy and the passage of the when the UVC passes when we put it in the umbilical vein. As you can see in the A, that is your umbilical vein path. When you just put in the UVC, then it enters into the portal sinus, that is B. Here, the portal sinus has got two branches, anterior and posterior. So C is ductus venosus anterior, and this is posterior one. So your UVC will come here when the portal sinus enters into the anterior branch, that is the ductus venosus, which later on continues as the hepatic vein, and then hepatic vein it enters into the IVC here, and then it moves to enter and should be ideally it should be left. The tip should be at the junction of IVC and RA. So this is the ideal position. So this is the route of the UVC. Generally, what happens is we generally try to look for the UVC from here. UVC will never come from here. If you see any catheter coming in the IVC from downwards, that means it is your PIC line. And that PIC line is basically from the lower limb. Okay. But this yellow one is the route for the UVC. The pink one will be the route for the PIC line from the lower limb. This we have just discussed the anatomy. So we should know the anatomy. So if your UVC here, you can see in this video, your UVC tip is up here. It is ending in somewhere in the sinusoidal sinus. Here, this anatomy I showed you. This portal sinus. So that thing is coming and ending here. So that tip of the UVC, when you see in this, is here, somewhere here, in the portal sinus or the portal sinus or the ductus venosus. It is crossed to here, so it is ending somewhere here, either in the portal sinus or the ductus venosus. The ideal point is here. So that means it is low lying. It has not reached its ideal point where it should be. So it is a low lying UVC. So that means normally when you see in the X-ray, you will see the UVC tip in the liver. So that means the UVC has not entered into central venous system. It is still in the vascular system of the liver, in the hepatic vascular system, either in the portal sinus or the ductus venosus. So that we call as the low UVC. And then if it is crossed the IVC and RA junction, then it is into either into RA or RV. It is known as the high lying UVC. So this is here. You see this UVC is in the liver. Either it is high or it is low. Here you can see this still in the portal sinus. So, and here is the ductus venosus. This is IVC. And when it enters, joins the IVC, this is the ideal. This is where the IVC is entering into RA. So this tip should have been here, but it is low. And here you can see the tip is just entering into RA. So it has crossed that junction. It is slightly high. Okay, so it is slightly high. So here you can see in this video, this is the IVC, this is the RA, and you see the tip somewhat here, this one. So clearly you can see this is a portal sinus. So this, it is low and the tip is in the portal sinus. So to look for the root of the UVC, you should look the vessels of the liver and not the IVC. And here you can see the tip UVC is crossing the RA and it has just entered the PFO. Here it has entered LA, so it is very high. So this is parasma short axis. Clearly you can see this is your tip and this whole UVC is in the LA. So it is high variety of UVC. So that is regarding the umbilical venous catheter. Now, if we will talk about UAC. UAC will be the umbilical arterial catheter, and that will be passing through the abdominal aorta. This is the normal anatomy. The ideal position, why we say either it is low, we put a low end of the UAC or a high tip at the higher end. So that is T8 to T10 is high, and the low is should be less below the L1 or L2 level, at the level of L3 or L4. Because here you have splenic vessels, so we should avoid this area, otherwise it can cause the hypoxia and the flow obstruction to the splenic vessels. So that's why either we leave it at to L3 or so, or we preferably put it at the high variety or high level, that is at T8 to T10. Then how to identify that whether this tip of the UAC is in the proper position or not. So here you can see this is the vertebral column, and just above the vertebral column you have the engorged vessel, that is abdominal aorta. In that you see this tip. So for both UAC and UVC, we do the subcostal views. The probe is to be kept in the just below the xiphisternum, and the pointer is pointing at 12 o'clock. If we sweep the probe towards the right side, it is UVC. And if we sweep the probe towards the left side, it is UAC. So you will see this UAC as per the sidedness if the situs is maintained. Here you can see the whole aorta, ascending aorta. This is the arch, 3 branches, and this is a descending aorta. Then the descending aorta is divided into 2. Just above the diaphragm, it is the thoracic descending aorta, and below the diaphragm, it is abdominal descending aorta. So the correct position of the UAC tip is T8 to T10, as I just told you. So either we can do one view in which we see the whole arch view, and we calculate the distance of this from the third branch of the aorta, or either we can do it at the celiac and SMA, which are at the level of L2. So diaphragm is mostly at the level of T12. So from celiac SMA, we do the distance. Okay. So how we do the distance, I will talk. This is the table which tells that. Arch view, when we do from the third branch of aortic arch in the arch view, the ideal distance, the correct position is, if the tip is at 5 to 7 centimeters, then that means it is at the level of T8 to T10. If it is less than 5 centimeters, that means it is above, it is high, it is above T8. And if it is more than 8 centimeters distance from there, it is lying below, it is low. And from the subcostal sagittal view, in where we see the UVC, from the view I showed you, celiac SMA trunk, the ideal distance of the UVC tip should be 3 to 5 centimeters. That means it is in the range of T8 to T10. If it is more than 5 centimeters, it is high, it is above T8. And if it is less than 3 centimeters, then that means it is below T10. This is the one. This is the abdominal aorta, celiac and SMA. We take a distance from here till this tip. If this distance is between 3 to 5, then means it is ideal, T8 to T10. Here you can see vertebral column, UAC, and here you can see this vessel. Just a second, just a second. Sorry for that. Okay. So now USA. So that was how to identify the UAC and UVC, and then how to identify the ET tip. These 3 things we have already discussed, because these are most common ones we put in our babies. We use that. Then the PIC lines, I told you, if you put it in the center, lower limb, so that will run through the IVC, and the tip can be localized in the IVC and at the IVC and RA junction. And if it is from the upper limb, then the tip has to be localized and seen at the SVC and RA junction. So USG guided center line insertion is again by ultrasound guided, and the probe we use. So three sites we use: internal jugular, subclavian, and femoral. Commonly we use femoral and internal jugular. Subclavian I personally use less because of the chances of complication like pneumothorax or so. So we use the hockey stick probe, that is a kind of linear array probe for the newborns. Okay. And this is how, like, it is in the lung ultrasound mode. So I will change the mode to the superficial vascular from my presets. Now, now you can see it has become big and very superficial. So I could see the vessels. With this is your hockey stick probes. And then we have to prepare for the aseptic precautions and cleaning of the probe. Either you should have a aseptic sleeve to cover it, or we do it with the gloves. I will show you. So with the gloves, first to clean the probe, either with the non-alcoholic sterile wipes or with the chlorhexidine. So these jellies, what we use, they are non-sterile. Either if we use the betadine gel, it will strain your probe, so that is not advisable. So here I'm showing it in the asterile glove, but after doing the surgical scrubbing and cleaning and washing and cleaning your hands and surgical wash and scrubs, you take the sterile glove and put this sterile jelly into that, concentrate it into the one or two fingers of the glove, and then you can insert the probe into this. So that becomes the medium for that, and your field will become sterile. The only thing you need to say is, here you see this hyperechoic line. So this is the layer, the glove, rubber layer of the glove. You should be aware of this. This is a kind of artifact, and you should not get it confused with anything in the baby's body. Always have an assistant with you. Do the full surgical scrub, gowning, capping, and prepare the trays as you do for the central line insertion. हेलो, मैं ना ऑनलाइन सेशन में हूँ एनएलएफ के पाठशाला में, कॉल बैक करता हूँ. So we do the gowning and all everything, the central line which you need to put the inserting needle, because this we do with the Schildinger's technique. Everything has to be a three-way cock, and you should prime it with the normal line so that there should not be any air. Okay, only the insertion, this is the guide wire. Only the insertion needle we will be doing with the ultrasound guided. Okay, so we will do. I'm doing the femoral. So you should clean this whole area where you are going to insert. This is for the internal jugular, femoral, and then subclavian. I'm not going to show you the subclavian. I will show you the internal jugular, and then I will show you the femoral, and I will do the procedure of the femoral. So for that, you need to slightly extend the hip and flex at the knee joint, and then clean it and cover with the whole towel. So all that precautions that you do for the central line insertions, everything you have to do. The baby is already having the UAC and UVC in situ. We do the cleaning for the 2 to 3 times. I have just edited the video to save time. Okay. So that's why I've shown you the cleaning procedure only for once. But as we do it for the regular central line insertions, you have to do the same way. And as you all know, the anatomy, this is a inguinal ligament. So the most lateral is femoral nerve. In the middle is the femoral artery, and the medial is the femoral vein. This is how it will look like. This is a probe marker, and then your probe orientation marker, where it is. If it is outwards, then the most medial one will be your femoral vein. So this is the vein. When you enter the needle, you will see. Can you see the hyperechoic? This thing is coming in. So when it enters, you can see the vein. This is a hyperechoic needle. So your needle has already entered the vein. Then so when you take a plunger, you withdraw, you will get to see the blood coming out, and then with the Selginder's technique, you can put the you withdraw, take off the probe, and then you take out this syringe. Okay, put in the guide wire. Don't insert it fully. Personally, what I do till it crosses your needle tip 1 to 2 centimeters, I stop there. Then we press the guide wire and take this inserter needle out. And then from there you can insert the catheter. So this is how. And then for the internal jugular, your carotid internal jugular vein will be on the lateral side. So it is on the lateral side. Femoral is medial. So this is how it will look like. Why these videos are not working? So here it will be here. So that's how you insert. So, so that was regarding the central line insertion. I know to just look at it looks easy, but you need to have the practice because it needs a coordination of two hands to when you insert. So mainly I will stress people, if you have seen this video and seeing this, you should just concentrate on how to localize the ET tip by the ultrasonography and how to localize the UAC and UVC because these are the three most common things we use in NICU and they are very easy to localize and hence we can decrease the use of um, uh, X-rays and pinpointedly we can point out where is the tip, how much distance it is low or above, and therefore we can correct and redo the things so that we can have the correct position, the tip, either the ET or the UAC and UVC. So with that, we complete the today's session. The next session will be the use of ultrasonography and in abdomen in NEC and all. So that we will discuss. Over to you, Dr. Vishal or Dr. Kunal.
Yeah. Thank you so much, sir. Vishal, are you there? Yeah.
Yes, yes. Yeah, thank you so much, sir. I think that was wonderful session, and I think I that is looks fascinating, but as rightly said by sir, it is a difficult task if you are doing with the ultrasound. Of course, in basically the femoral one is very helpful when we go for the device closure, sir. Like for PDA device closure, generally cardiologists sometimes could not insert the femoral vein, and by ultrasound we are doing, to canalize the things, and after that the device will go through that one. So there is another things, it is very helpful, specifically the PDA one. So that was very nice. And second thing, I think sir rightly said that UVC is always in the ductus arteriosus, so we need to chase through that one RA-IVC junction rather than the find in the IVC. So that is another point to be learned by everyone. And sir, in UK, what we are doing, like generally there is a one study we were doing over there that generally two-person are scrub, one who is doing a POCUS and another is the inserter, and generally we used to insert the line through the either saphenous or either from the elbow, and by live doing ultrasound we just withdraw the line till we can see into the SVC. So that way, I think we used to do over here also sometime. So that is I think one of the another way to do that one. But of course, it is a time consuming. A 2-3 person has to be scrubbed at the same time. So thank you so much, sir, for doing this one. Anything from Kunal? Jatin is also joined. So any input from Jatin? Jatin bhai is there.
Sir, just wanted to ask which view do most of the units prefer, whether it is transverse view for inserting the line or the longitudinal view? Uh, which one is
So I
useful?
intentionally missed that, but normally maximum people they use the transverse,
Transverse.
not the longitudinal, because the area where they can insert becomes very narrow if we use longitudinal. So I
Okay.
also personally use transverse, no, not longitudinal. Very few people they use longitudinal one.
Okay.
Sir, anesthetic is specifically used that अपना आपलो which echo machine for that one particularly. I forget the name. The commonest one.
Sonocyte.
Sonosite. So they have different box shape machine they have. I don't know the model name. That is a good for the procedure. Generally, anesthetics over there using that one. I forget the model's name. एक
But the
डब्बा
thing
जैसा
is,
आता है
because
वेंटिलेटर जैसा आता है सर so that is a
but it
particular
is the thing is basically that is for their procedural this thing, and they have the
uh,
needle correction mode also. Now all the
yeah
machines
so
have got that mode. Even the
okay
Philips and GE also has got the mode. So
the
there
only thing
you
we need to buy
can.
the hockey stick because with the transverse
Yes,
big probe it is difficult to
it is difficult.
do that one yeah because I try
Newborns
over
work
here
with the hockey stick.
but yeah so but it is difficult to this minor movement also like you counter the vein or artery.
Yeah.
Okay, sir. So I think if there are no further questions, we can end the session, sir. It was a very informative and useful topic, and as usual, your beautiful, colorful slides made it more
Yeah.
interesting. So thank you so much, sir. Uh, this will be on the YouTube later also if anybody wants to see. And thank you all. Thank you, Mohit sir. Again, thank you, Vishal and Jatin and Kajal ma'am for joining. Thank you. Thank you, ClearNet. Sriyashi, we can end the session now.
Thank you sir. Bye Kunal, thank you sir.
Bye. Bye.
Bye.
Sriyashi, are you there?
Yes, sir.
Yeah, we can end the session.
Yeah. Thank you, sir. Thank you so much, everyone, for giving us the opportunity to host the session. So, with this, we are concluding the session over here for today. Thank you. Have a nice day to all of you.
Thank you, Sim.
Thank you, sir.